Okay, I'm here with my good friend, Dr. Chad Larson. And Chad Larson is a DC and a naturopath. We actually went to school together. He was a semester ahead of me. We practiced together for about 5 years. And then he then went to naturopathic school and then he came back home. And then now we're been good friends ever since. And Chad's an expert in many things, and he's actually a phenomenal functional medicine practitioner. And I remember when we first practiced, we would do blood chemistry panels on every single new patient. We had a little side office in the gym when we were starting our practice, and we were working with different personal trainers there and trying to build our practice and things. That was a lot of fun. So these days, Chad, what are you focused on mostly? I know you do a lot of things, but I know you work with chronic pain, and I know you're an expert in that. And I wanted to talk to you about chronic pain. But is that something that you enjoy doing? Is that something that you just feel there's a big need for it? What do you find?
Well, first of all, thanks for having me, DT. It's great to be with you. Yeah, you just brought back some really awesome memories starting out early on. We had such a great time. I remember when there was literally three charts, back when we did paper charts, three charts sitting in our file cabinet. And as we just kept growing and, getting out there in the community, that grew to, one shelf and another shelf. And eventually we had to move out of that office because we just kind of outgrew it. So those really fond memories. Yeah. So, chronic pain it's endemic. It's something that, is probably the number one reason why people visit doctors. And it's something that those of us in functional natural medicine, literally, I think in many ways take a complete inverse approach to what the kind of standard conventional approach is. And because the standard conventional approach of just symptom suppression has clearly failed over and over and over again. And so we take an approach that we got to look at the whole body, and it's just a inconvenient fact that that's the way to do it. You can't just have tunnel vision on where the person's pain is, and you have to take a look at everything. And it's hard. It's not easy work. It's difficult from a practitioner standpoint because you got to kind of know a little bit of everything. And it's difficult for the patient because we're looking at everything. We're going into their biology and their lifestyle and their diet, and we're uncovering as many components as we can, because the more things that we can put together, the greater the chance that they're going to help to decrease their chronic pain.
Yeah. So I know you're well respected in the community, and you see a lot of chronic patients. But for someone who is, let's say, practicing a conventional chiropractic office or acupuncture practice, and they're going to be seeing pain patients all the time, how do you start that discussion with, I got to treat more than your back pain or shoulder pain? Or what do you think would be good advice for them?
For the practitioner you talked about, right? The starting out practitioner.
Yeah. Practitioner.
I think it really starts with a good comprehensive history. You and I were trained by Dr. George Goodhart early on, and he said, shut up and listen. Your patient's going to tell you what's wrong with them. And that's where it's got to start initially, is we have to take a comprehensive history, find out where they've come from, what kind of injuries they've had, what their diet is like, what their lifestyle is like, what's their home environment, their work environment. We have to take all those things into account. So it kind of starts there with really good history. Don't skip that part as a provider. It's a really important part. And then you got to do a thorough, physical examination. That oftentimes also I've seen not be as primary in some practitioners' practice. They skip that part. And I don't get it. I literally wouldn't know what to do with a patient if I didn't do some kind of physical examination. We got to feel what's going on and, test a bunch of different things. And then you got to put that sort of subjective information with some objective laboratory information. And the way I explain it to patients is we're going to put all that stuff together and overlay it relative to what their issues are, and kind of view those results through the lens of their issue, of the reason why they're coming into the practice, and then come up with a comprehensive plan based on all that information. So again, it's a deep dive historically, it's a deep dive with clinical examination, and then also laboratory testing, and then putting all that stuff together and coming out with an individual plan for that person.
So Chad, if someone has like chronic pain, let's say chronic back pain or something, right? Or a chronic injury that just isn't healing, what are the main dietary things you see cause that? Is it prostaglandin imbalances? Is it food sensitivities? Is it leaky gut? Is it all the above? Or what are like the top things to look at when someone's trying to like a chronic pain from dietary triggers?
Yeah. Yeah. So, as we know, a study from a couple of years ago indicated that only 12% of adults in the U.S. are metabolically healthy. So 88 some percent are metabolically unhealthy, and that just promotes general systemic inflammation. And you can take an MRI of 10 adult, let's say 40 to 45-year-old adults, look at an MRI of their back, and you'll see some degree of degeneration, but maybe only 5 out of those 10 actually have symptoms of low back pain. So what's the difference between the two? Oftentimes it's systemic inflammation. What we don't want to get too hung up on is something like, somebody brings in an MRI, maybe from another provider that maybe did some cortisone injections, said, hey, these cortisone injections kind of failed. I'm still having pain. What can you do about this? Can you do some treatment for this? And we can't just treat the MRI image. We have to, again, take a full kind of comprehensive approach, because some of these people who are metabolically unhealthy, that needs to be the centerpiece. Oftentimes before we even do regenerative injections or some kind of physiotherapy situation or acupuncture or something, we have to make sure that their ability to heal is maximized. And if somebody is metabolically unhealthy, then that's going to really inhibit their ability to heal. Whatever modality we're using to help support the ligaments and tendons and muscles and bones, it's going to be really influenced by their food choices. So, I mean, for sure, the foods, kind of the lowest hanging fruit is liquid sugar. If somebody's drinking, sugar sweetened sodas or something, that's a non-negotiable. That's not even something that we can negotiate on. Okay, every now and again, in moderation. Okay, if you want moderate results or moderate chronic low back pain, okay, keep drinking the moderate amount of soda. But it's got to be a non-negotiable, because if somebody's going to hire me and pay me to help them, I want to really help to maximize their therapeutic result. And if we're not working from the inside and the outside in, then they're going to have only limited results. So there's certain things that are non-negotiables. I'd say the liquid sugar is a non-negotiable. And then from there, we're looking at foods that have added sugar. Anything with added sugar, look at the label. If there's added sugar anywhere on the list, then that's not a food that's going to be promoting any kind of healing, any kind of metabolic health, any type of balancing of the inflammation system in the body. And then kind of next up on the list are maybe foods that are processed. Maybe there's not actually added sugar to it, but it's a highly processed grain. It's the processing of these carbohydrates that make them poisonous for our system. And so we have to really kind of limit at least. Maybe some of those are a little bit negotiable, but we have to, be mindful of where that person is at metabolically. And, so we'll have to make some adjustments to those. I really lead with protein, a variety of protein. I kind of prefer animal protein for most people. If there's a vegan or vegetarian, then we'll have to kind of work around that. But if they're okay with animal proteins, I want to lead with animal protein, because the things that we're trying to rehabilitate and trying to create some regeneration, those are going to require amino acids and proteins. And when I've done diet analyses and diet diaries, and we evaluate kind of the macronutrients, the carbs, fats, and proteins in people's diets, almost always they're protein insufficient. And so oftentimes I'm going to be ramping up some protein, and then I want to fill the rest of the plate with vegetables, a combination of leafy greens, sulfur-rich vegetables, and then high polyphenol-rich vegetables. And those are the things that are going to promote healing. And so it's kind of like two sides of the coin. We want to get rid of the pro-inflammatory foods, and we want to really feature the anti-inflammatory and, kind of building block type foods to help maximize their regeneration and decrease their pain.
Chad, you pointed out a couple of things I really want to push you a little more into, because I think they're really important. One of them was sugar and metabolic fitness, and a lot of it has to do with insulin resistance and insulin triggers. What do you think about people that do a lot of fruit smoothies and fruit drinks. And what do you see as that impact on pain versus just like the soda? Because we have people that, have basically fruit in, smoothies and fruit drinks all day, maybe add a little bit of green to it, but it's basically bananas and lots of sugar and things like that.
I know.
What do you do with those?
It's such a problem. I mean, like, if people get the healthy foods from Jamba Juice, I'm really concerned about them.
Right.
And no rub on Jamba Juice, but I mean, those are really concentrated fruit juice. If you look at the sugar content, it's just off the chart.
Yeah.
And a lot of it's fructose, and we could talk about fructose, as a thing, but yeah, it's those concentrated juices. It's up there in some cases, maybe even worse, or certainly just as bad as soda. And they're just loaded with sugar, and it really kind of freaks out their whole, blood sugar rhythm. They get really sharp, increases of glucose. And hopefully, if they're insulin sensitive, their blood sugar is going to drop, and then they're like a reactive hypoglycemic state. And then they're just stuck on that blood sugar roller coaster. And it does not promote healing. In fact, it promotes inflammation in the system. So absolutely, those kind of liquid sugars also are, just got to get off the list. A lot of people are drinking, they're, in their fasted in the morning, and they're drinking celery juice, and they think that's, a health thing for them. I'm not a fan of drinking celery juice in the morning, even though that's coming from the vegetable. There's still things in there that are, I think we could do better than that. Other vegetable juices, I think, could be awesome. But when you start, increasing fruit type juices, and you're taking away all the other constituents of the fruit, then that's just not that's not what our biology is expecting. That kind of dose of sugar is just too much for the body to handle.
Right. I mean, I've seen that the person whose blood sugar is dropping all the time, they're crashing, they're hypoglycemic, and they have like a smoothie for lunch, and then, or they have an acai bowl with honey on it, or, and I mean, what's all natural? It's all healthy. I don't know what you're talking about. Like,
yeah, exactly.
Yeah, like you're a roller coaster. So it's a very interesting pattern people should know about. And then the other thing you mentioned was the vegan, vegetarian, or maybe the person that can have protein. How do you deal with like at my point in my practice now with chronic patients? I don't think I can work with a person who's like a full vegan. I don't like, it's too hard. Like I mean, it's, you get tired, you get old, you get cranky. Like I don't want this patient. It's gonna be too much work. I'd rather just I don't have the energy for it. And not to say there are practice veganism healthy, because there are, they're highly trained in nutrition, and they're very focused, and they really put a lot of effort into it. And then we also see a lot of junk food vegetarians, right? That basically don't eat meat, but everything they eat is like, processed vegetarian meat-like foods and all that. So tell me what you're doing with them, because I don't know what to do. And I'm at the point where since I don't know what to do, I give up on them and not take them but as patients. But what are you doing that's working?
Yeah, I don't have a lot of them, but there are a small handful, and they're challenging, and they oftentimes come in very fatigued, and they are, quite weak. Oftentimes they've got pain, they've got instability of their joints, because I think oftentimes they just don't have the building blocks for normal regeneration and repair. And we have to have, some challenging conversations, and oftentimes there's just absolutely no way that they're gonna start eating animal products. So I try to work with them where they're at, but it is difficult. And I get where you're coming from, to just say, look, if you're vegan, you got to go somewhere else. I just can't help you. I get that for sure. But I think there's some ways that we can do it. And, I'm going to do comprehensive labs on them, and I'm going to find really where their deficiencies are. So it's not just my verbal recommendation. We could see it just very clear in black and white that things are deficient, things are off, they're missing building blocks. And every now and again, honestly, this isn't a goal. I'm not trying to, break somebody of their veganism, but through conversations and maybe laboratory testing and kind of seeing where they're coming from, sometimes I could actually increase a little bit of, maybe some white fish or something, some very, easy protein. But if have stayed very, vegan, we're probably going to have to do a lot of supplementation. We're probably going to supplement with some, vegan-based proteins, protein powders, which we could talk about those. Some are good, some are, I think, horrible. But yeah, we probably have to do a lot of supplementation, because a lot, it's an extreme diet. Veganism is an extreme diet. I'd say maybe on the maybe opposite end of the spectrum would be like a ketogenic diet. And they're extreme and they're very difficult. And most people default to a lazy vegan diet and a lazy keto diet. And they're not actually eating whole foods, and they're eating a lot of packaged food. Just because the package says vegan, the package says keto, then, oh, I'm maintaining keto, I'm maintaining my vegan diet. It's junk. It's completely processed, fake, not real food. You barely have to chew it. It's not not what our biology is expecting. And so yeah, if people want to maintain a vegan diet, I explain that sometimes I think I eat more vegetables than many vegans, and they have to go back to, eating whole foods in as much as they can. So some people can tolerate it, some people can't. Sometimes we identify that they actually have reactions to, high lectin rich foods. And if we take those out, they literally aren't going to have any protein in their diet.
Yeah.
So it kind of runs the spectrum, but they're more difficult.
I agree. And just to defend myself, since I work with a lot of autoimmune patients, and if they're vegan, and it's the same thing, they're lectins and they react to all the foods they're eating, and it's like there's nothing left to eat and you can't get protein, it becomes really hard. So I'm not anti-vegan. I'm just in the clinical story where it's hard to help people heal when they're chronic and they need protein and they're reacting to all the vegetables and foods they're eating and they're just weak and frail. So let's talk about protein. You mentioned something that's really important. You talk about protein powders, and some of them are total garbage. And for myself, I found I just don't use protein powders anymore. I just find like the whole process of making them, and they all get hydrolyzed and they become actually very reactive, and a lot of people react to them. Are you seeing similar things, or what are you doing with protein powders?
Yeah,
I know you need protein.
Most people react to them. I think they're concentrated. I want my patients to chew their proteins. I don't want them to drink their proteins. And I think there's some important process of actually, chewing the protein. There's things that are going on that we maybe don't even know about that I think are important for them physiologically. And to, drink a protein, first of all, it's highly processed. Oftentimes it's pea protein if it's plant-based, and some other things that are really high in lectins that I think a lot of people are reacting to. Some companies try to put, enzymes to try to buffer that effect. And so they're trying to balance it out. But yeah, it's not a place that I want to start off with people. And same thing even with other types of, like whey protein. So many of my patients are reactive to dairy proteins. And as far as like amino acid complexity and quantity, I think whey protein is probably the most superior. But I have so many patients that would be able to so few patients I'd be able to tolerate it. I wouldn't be able to tolerate it myself, and most of my patients couldn't. So I do try to, I try to evaluate to see actually if they have immune reactivity to dairy, to really take the guesswork out. But sometimes they already know just from their diet that they react to dairy products. And so unfortunately, even though whey would probably be at the top of the list if it was a very tolerable substance, even that I'm very concerned about people over consuming whey protein. I think it's very immunogenic.
Yeah, I totally agree. I mean, I think I've had like some patients where that was the key factor, like get off your whey protein. Oh, I thought it was good for me. I mean, technically it's good, but it's a processed protein. It's high, it's very immune reactive. Whey for sure is a major issue. So you also mentioned ketogenic diet and extreme diet and not doing keto properly. So obviously ketogenic diets can be very effective in lowering insulin, helping with chronic pain, but then there's some issues with that. And then you get the ketogenic diet who's like eating all milk and all dairy products and lots of inflammatory foods and fried bacon all the time and like lots of pro-inflammatory prostaglandins. What are your observations? What kind of things are you seeing with ketogenic diet and chronic pain and some of your expertise on that topic?
Yeah, if somebody has some fairly significant blood sugar dysregulation, it could be a way to really get out all of the processed and general carbohydrates in their system. And kind of, I think it could be helpful as a short-term reset for their blood sugar metabolism. But then slowly but surely, I want to start to increase their complex carbohydrates back in their diet. I think there's so many micronutrients and polyphenol nutrients in foods that they don't maybe have a deficiency name like we know with like scurvy and beriberi and these different things, we can name certain vitamin deficiency conditions. But I think there's actually polyphenol type deficiency conditions that we don't really have a name for. Maybe we just have chronic disease or chronic inflammation. I want people to feature those in their diet, and just a couple servings of broccoli would probably kick most people out of ketosis. So I think it's a good tool to have. I think there are other ways. There's sort of nutritional ketosis. There's also fasting ketosis. So I think the way our physiology is built is this is just my sense of it. Maybe I haven't proven this, kind of scientifically, but I think that it's natural for us to kind of come in and out of ketosis. I don't think that most people benefit from chronic long-term ketosis. Maybe if they have, there's been some interesting studies on cancer and ketosis and other extreme, maybe certain types of chronic issues and blood sugar dysregulation, maybe a longer term. But I think for most people that are either, well patients or have, moderate issues, I think maybe using ketosis as a tool, I think could be helpful. But being on a chronic ketogenic diet, I think has some long-term consequences, especially because people aren't going to do it really correctly over a long period of time. It's just very difficult to sustain.
So talk to me about like a scenario. So when someone comes in with chronic pain, let's say they have chronic insulin surges and insulin resistance, and you want to use ketogenic in the short term and then transition into nutritional ketosis and ketosis period. So give me what you're doing with what's a typical time frame, an average or something.
Yeah. So the first thing is, it's kind of like going to a financial planner. It's, you go to a financial planner, you're like, hey, I want you to help me with my finances. They go, okay, I need some data. I need to find out your income. I got to find out your expenses. And then I'll be able to help, whatever your goals are with your finances, then, we can make those appropriate changes. Same thing with diet. I first want to look at what is their degree of blood sugar regulation. And then we got to do a diet diary. There's some really important things that can come out. A recall diet, those have been shown to just be completely useless. Somebody trying to think at the end of the day, here's what I ate today. We're terrible historians of our diet. So this has to be, inputted into hopefully like an app on your phone or a computer right when you're consuming it. Everything that goes in your mouth is recorded, and then we can get some better data. And we have to start with that information. What is your macronutrient, kind of balance initially? What are your proteins, fats, and carbohydrates? And then I kind of speak with them about kind of their personality type and, how do you like to make changes? Some people are like, boom, cold turkey, let's go for it. Frankly, those are kind of a smaller percentage. Some would rather take slow steps into it. And so we start to squeeze down on their carbohydrates while I like to kind of create their macronutrient profile first with, okay, here's the amount of protein that I want you to maintain during the day. And at that amount of protein, here's the amount of carbohydrates that we have to squeeze down. And then we're going to use fats as just kind of a satiating kind of macronutrient. Fats, I think in kind of a classic ketogenic diet, probably make up like 80% of the calories is all fat. In what I'm talking about, where it's maybe you'd call it sort of a modified ketogenic diet, where we're using fats to kind of fill out the rest of the calories and fill out kind of satiation, but I still want to use protein as my lead macronutrient. And we're going to be decreasing the carbohydrates. First, like we talked about earlier, getting rid of all the low-hanging fruit, really, really high, processed kind of carbohydrates, get all those out. And then eventually we have to start squeezing down on like the fruits and the root vegetables until we get to a sweet spot where we can actually start to monitor their degree of ketosis and try to get them in some at least low degree of ketosis more often than not. And we'll maintain that for a period of time until we really start to see some changes in their body weight management and maybe their blood sugar regulation. And then we start to slowly creep back in the carbohydrates, and we try to find a sweet spot that is sustainable for them, because that's the key thing. I'm not trying to just develop some, pretty looking protocol that's just going to sit on the shelf somewhere. I want it to be very doable, and I want them to enjoy their food, and they should, come to a meal hungry and walk away from the meal happy and satisfied and they enjoyed it, that's part of life. That's important. And so we have to kind of toggle between those different things. And so I'll slowly kind of start to increase the carbohydrate until some of the kind of the effects of the ketogenic diet start to change. And then depending on what kind of improvements they have, we'll make little adjustments as we go.
Okay. So if you have, let's say, a person who's getting ketosis and maybe for whatever reason, maybe they're pre-diabetic or trying to just lower their insulin really way, quickly, or maybe they had a brain injury, maybe they have brain inflammation or something, trying to get them ketosis to help them recover or whatever the situation is. Once you figure out their diet and they start to get into ketosis, you're measuring ketone levels with them, right? And you're doing serum, urine. What do you prefer?
I prefer doing the finger prick test, like
Keto Mojo.
Like the Keto Mojo. Abbott has Precision Extra. Those are, you can get those on Amazon. The expensive part is the actual ketone strip. The prices come down over time. Those little suckers are kind of expensive. Yeah. But so they want to get a bunch of those, and they can buy it in sort of bulk, and kind of makes the price go down. But yeah, we'll have them monitor that at kind of consistent intervals, so we could see what's happening during the day. They'll also get glucose strips, so we can monitor their glucose along with the ketones.
And when you're looking at the ketones, are you in the keto world, it's like you have to have your ketones as high as possible, and then they like make people eat all these fats, get their ketone levels go up. But clinically, for me, I don't know what you're seeing. When I see them just have some ketone development, even if it's just a little bit of ketosis, they're in the physiological state where I need them for their benefits. Is that what you're seeing, or do you think you need to increase it, or what are your observations?
No, it becomes kind of like a battle of how high we can get the ketones up, and I don't really get that kind of situation. But yeah, I think as long as they're in some degree of ketosis, then I think that's where and then from there it's individual. How do you feel at that level of ketosis? Oh, okay, I feel good. I feel energized. I've got my fatigue is gone. My brain is just firing. I feel like I'm sleeping really good. Oftentimes I want to use the number as kind of a little bit of a guide, but also we're treating the person, not the numbers, not the lab test, not what the monitor is saying. And so I want to know how they feel at those particular levels. And that could help us, kind of determine what is their most appropriate number. And it's different, from person to person.
Yeah. And it's pretty common to see people get into ketosis and have their pain go down. Have you noticed?
Yeah, that's really common. I mean, ketones, I think, do something pretty unique and special. The way that they're utilized by our cells, they don't have as much of a inflammatory, kind of side effect. And so there's kind of a net anti-inflammatory effects, it seems, if somebody could move into ketosis on a regular basis. And so I think most of the time people do feel better when they're in ketosis. So if we can at least use that intermittently, but even when they're not full blown in, kind of official ketosis, if we could still keep their blood sugar, very regulated, then that's a big bonus in helping to control their chronic pain.
Okay. And then when do you decide to kind of transition them out of ketosis? Is when you see them like, this is dire, I'm tired of doing this, or do you see like their symptoms? Do you see like depression coming in, or do you see, or on the other hand, do you see people like, oh, I don't want to change, I feel great, I'm not going back to adding anything in right now?
Exactly. It's totally that conversation. Yeah, trying to stay in contact with them, and how are you doing with this? Does it still feel sustainable to you? Are you enjoying how you feel? Yes, I do feel good, but I really miss carbohydrates, and I feel like my, in some cases I might say I feel like my performance, in the gym or something is going down a little bit, or when I run, I feel like I'm missing that extra kick that I had when I had more carbohydrates in our diet. Then I go, okay, cool. Let's start to dose in a little bit more carbohydrates. See if we could still maintain your mental focus and sharpness, and maintain your body weight management, your blood sugar management, but yet you could still have maybe a little bit extra glucose in your system. And so we'll kind of titrate in a little bit more carbohydrate, monitor with the ketones and the glucose monitor, and monitor how they feel, and then see if we can hit sort of a sweet spot for them.
And at that point, ketone measurements are not as critical, right?
Yeah, I mean, they'll get kicked out of ketosis with a fairly, moderate amount of carbohydrates. So, and some people, we end up doing kind of, there's probably a term for this, and it might not be perfectly for that term, but maybe kind of a cyclic or intermittent ketosis, to where if we can put them in a little bit of ketosis on a regular basis, we can help them maintain the benefits of ketosis, but also still include a broader variety diet where they can enjoy some things that are more, carbohydrate rich. So yeah, I mean, monitor and adjust, but I think intermittent ketosis is where most people end up settling.
And Chad, with the intermittent ketosis, are you doing like time restricted feeding? What are you doing to achieve that?
Yeah. And it's kind of up to the patient. We explain that, if they come into the office with chronic pain and they had, metabolic dysfunction and maybe some blood sugar dysregulation, then when we get to the conversation around diet, it's just explained straight up that something has to be restricted. Either there's going to be a macronutrient, probably carbohydrate, that's going to be restricted, or there's going to be caloric restriction, or there's going to be restriction in the timing of the diet. Because, when they study this stuff, most Americans are eating like 15 hours a day. The only time that they're not eating is when they're physically horizontal in bed. Other than that, first thing in the morning, bam, there goes, an English muffin. And then at night, just before bed, they're having some kind of ice cream or a snack or something. And this is not how our physiology has evolved over time. We've evolved to have pretty significant, I think, chunks of time where we're not eating anything. And there's so many amazing physiological attributes that we have. This medicine chest just comes out in the system when there's no food that the body has to deal with. So I like to really use that attribute that we have to our advantage. And oftentimes, depending on what we're restricting, and sometimes we can stack it, and we can use sort of a caloric restriction and a food timing restriction together. And maybe we will start, oftentimes these people are starting with a 15-hour eating window. Let's just start with 12 and 12. Let's start with a 12-hour overnight fasted period and a 12-hour eating window. So, 8 a.m. to 8 p.m. kind of thing. And let's just start there. And in some people, that makes massive change. And we just hover there because they're like, oh, I feel better. I'm sleeping better. My energy is better. Okay, cool. And if they want to kind of move to the next level, or if there's a little bit more improvement to be had, maybe we'll start to squeeze it to a 12-hour, a 14-hour, overnight fast and a 10-hour eating window. And that's probably on average where most people settle. If we're using kind of a time restricted or intermittent fasting kind of protocol, usually around 12 to 14. Some people love 16. And so we'll do that. That's probably a lower percentage of my population of patients, but 12 to 14 is where I'm trying to get most people. And then we get kind of the caloric restricted effect from that. We get the time restriction, get a little autophagy. We get a little bit of probably mild ketosis if the rest of their diet is pretty low carbohydrate. And so there's lots of physiological advantages of making, the fairly subtle changes.
Right. And do you find if they do a ketogenic diet first and they get keto adapted and learn how to use their fat for energy force, it's easier for them to do the time restricted feeding? Or have you
Oh yeah. I mean, it's a goal. I mean, I named my practice the Adapt Lab. And the whole point of that, and kind of the subtitle, is metabolic regeneration, because I think it's our biggest issue as healthcare providers. Metabolic syndrome and metabolic issues, I think, is our number one problem. And that stat that I mentioned at the beginning, that only 12% of adults are metabolically healthy, it is the problem of our lifetime. And that study actually included 20-year-olds. So even with 20-year-olds included in that statistic, still only 12%. Imagine if they started the statistic at like 35 or 40. I mean, that 12% would be like 5% if we're lucky. And right. So it's a major problem. And it's something that, that I think we all have to focus on. I think those of us in naturopathic and functional natural medicine are uniquely suited for this problem. In fact, I think we're maybe the only ones. I think those who are kind of conventionally trained in pharmaceutical-based medicine, I think some of them were trained that way, and they've kind of come over to sort of our side of more comprehensive, kind of natural medicine, and that's working for them and working for their patients. But I think we're the only ones that are really suited for this issue, and really, it's the issue of our lifetime. And it's something that if I can get somebody to be fat adapted, if I can get them to be able to use fat for fuel in between meals, I've done my job with them. And we can do lots of fine tuning around the edges, but if I can get somebody to become fat adapted, and whether or not they actually go ketosis, I think is a lesser part of that. But if I can get them to use fat for fuel, to switch between using glucose for fuel and fat for fuel, I think I've done a really positive thing for them.
Right. So just to kind of recap, tell me if I'm on the same page. But with chronic pain, you have people that have these blood sugar dysregulations all over the place, and insulin surges or hypoglycemia events, and those create inflammatory chronic pain patterns. Then we have the skinny, hypoglycemic, maybe even vegan, protein deficient people that have chronic pain. They may appear healthy, but they're really inflamed and don't feel well. Then we have those that are overweight, more of metabolic syndrome and insulin resistance. And you do keto adapt, and ultimately with either of those body types or clinical presentations, if they can get some keto adaptation, where they're not playing a roller coaster ride if they're hypoglycemic, or they're not playing that chronic insulin ride, and they can start to make ketones and get in periods of time where they're making ketones that has an anti-inflammatory effect, helps modulate their pain, right?
Oh yeah.
Okay.
Yeah. And there's lots of things, lots of techniques and things. We can do acupuncture, we can do things like prolotherapy and regenerative injections, and we can do all this stuff, but it's really key to know that they're going to be able to respond to the treatments. And that's where I think we can do, kind of external treatments for them, but we have to make sure their internal environment is ready to regenerate. It has the construction crew ready to go. And so we can't do one without the other. I think we oftentimes need to start, at least in conjunction with those therapies. We have to, make sure that they're metabolically healthy before we start going into these. And right. Yeah, you're right. There's all kinds of different, body types. And, we know, you and I know way back from, learning from Phil Maffetone years ago, that fitness and health are not synonymous. And so somebody could look fit, but internally be very unhealthy.
Yeah, I remember we were seeing a lot of athletes and triathletes, and we're going, "Oh my God, we're looking at their labs together. What happened? They're running the Ironman." And you had a patient who I think won the Hawaii Ironman, and his blood test was crazy. And
I know, yeah, it's and that's why we want to look at those objective measurements, because it could really give us some information that we just can't get clinically. We can get a lot clinically, but there's a lot of things that I'm surprised. I think probably almost every time I run lab work, there's something in there that I go, I'm so glad we ran this lab work, because right. I wouldn't have known this clinically. And that's some really powerful information to have.
So protein is critical for healing. And so, just to kind of put some of the pieces together, people that aren't recovering from an injury or chronic pain, that's ongoing inflammation, or they might have enough protein to support tissue regeneration. But then let's talk about fats, right? I'm sure you're seeing what I'm seeing and other people are seeing, which is people that are just not getting enough healthy fats in, right? They're not getting the diversity of different prostaglandins in. And what kind of tips can you give us on looking for healthy fat intake and unhealthy fat intake, and what kind of adjustments are you doing as a clinician to help with chronic pain?
Yeah, it's very similar. It's a very important part, I think, of the conversation that is maybe overlooked, which is, it's very much like the sugar conversation that we had, where there's kind of a spectrum. There's some that are worse than others, and there's kind of two sides of the coin. We have the one side of the coin where we want to try to decrease the pro-inflammatory type fats in their diet, while at the same time increasing their anti-inflammatory, healthy, natural fats. And so it's another, I want to say it's non-negotiable. Some people have a really hard time completely eliminating it from their diet, but the highly, processed vegetable, fats, it's such a marketing term. There's nothing vegetable about a vegetable fat. It's a fat that started out as like a bean or a seed, and it under massive heat, massive chemical laboratory manipulation, somehow you get some oil out of that. And it's so inflammatory, so inflammatory. I evaluate people's omega-3, omega-6, and RBC levels of omega-3s, and it is literally off every single time until we start creating a better balance. So people just don't realize that the soybean oil that's in their cracker or chip, or the canola oil, or just some highly processed oil, it's pro-inflammatory. Most people are walking around in a net pro-inflammatory state, and we need to turn them into a net anti-inflammatory situation. And balancing fats, in addition to the sugars that we talked about, is a major lever for us to pull on. And oftentimes it's just educating. I pull up examples, right, in the office, and I have them, this is the label, this is the food that you're consuming, this fat right here, every time you consume this is putting you into a pro-inflammatory state. And we're trying to support their knee or their lumbar spine, or something in their body. And every time they consume that, I just want them to realize that they are contributing to their pain and their inflammation every time they consume that. And once they get that, then I just want them to be an informed consumer. And if they choose, like, okay, I know he told me when I have this corn chip, which is from a genetically modified corn, and it has some kind of probably corn oil, it's going to put me in a pro-inflammatory state. If they choose to eat that, I actually have no judgment about that, because I inform them. They're making an informed decision. That's ultimately what I want them to do. And hopefully, more often than not, for our purposes, they're going to not consume that very much, if at all. But if they choose to, they made an informed decision, and that's on them at that point. And, I'm relatively okay with that. I want them to feel better, and I want success with my patients. But that's on the side of kind of what we want to get rid of out of their diet. And then, then there's just lots of other good, healthy, natural fats that people could utilize in their diet, which could be more, anti-inflammatory. We have, fish oil.
Before you go in there, I want to touch on something. How often are you doing the omega-3, 6 fatty acid testing? And
I would like to do it on every patient. It's part of just my general lab work, because I can guess on it and I can make the right decision clinically, which is, okay, I'm just gonna, here's the list of foods I want you to consume, and here's some supplements that we can take to help promote, better balance in your omegas. But it's oftentimes pretty powerful when people see it in black and white, and they look at the ratios and they're like, oh my God, that's, they see the numbers, and it seems to be helpful.
Which lab do you like to use for that?
There's different ways that we can look at omega-3, omega-6 ratio. I've been using lately Vibrant. Vibrant has a lab where they take a pretty deep dive with their omega-3 and omega-6. They look at both serum and cellular RBC levels, and they give us a ratios of arachidonic acid and EPA. And I honestly, unless somebody is making a really strong effort already in their diet and their supplementation, I see their arachidonic to EPA ratio off every single time. And then we get, an omega-3 index RBC levels, which is pretty sophisticated marker. And I see that low all the time. And so people, again, are walking around in a pro-inflammatory state until we start to do something about that.
And with those profiles, tell me if you're saying the same thing. Sometimes you'll see something low and you supplement them with that, and then it doesn't change it. And it's not like until you go after their underlying inflammatory mechanism that these patterns actually change. So it's not as simple as just like what's low on the report is what they need. It's just what's on the report is changing how their fatty acids being processed. But a lot of times you have to go deeper. Are you seeing the same thing?
Absolutely. It's those two sides of the coin. Not only do we have to promote the more anti-inflammatory fatty acids, but we also at the same time decrease the pro-inflammatory fatty acids. They both have to happen. Otherwise, we're just going to be spinning our wheels. And we don't, I don't want somebody to have to, supplement for the rest of their life. I would like them to be able to do this with their diet. But at the beginning, we almost always have to supplement. And so I want to look for, high EPA content fish oils. And then we talk about the smash fish, the salmon, mackerel, anchovies, sardines, and herring. A lot of the oily fish that people are like, in our culture, people don't eat that stuff. But we talk about some different ways that you can get that into your diet. And some people, tolerate at least a couple of those. But then there's still other ways that we can get healthy fats in their system as well.
What is things like food sensitivity, leaky gut, those types of reactions come into chronic pain for you?
They are the centerpiece. I mean, we talked about so many things that are already the centerpiece.
Right.
But see, this is what we talked about at the beginning, right? We talked about we can't have tunnel vision on their pain. We have to consider all the physiologic processes, and it's just it's an inconvenient fact that you just have to look at all this stuff, especially with our chronic pain patients. You have to look at all the different sources of issue. I think so many people with chronic pain probably have some immune system dysregulation, even if it's not a full-blown autoimmune condition. I think there's so much autoimmune, let's say autoimmunity that's happening without actually being an autoimmune disease. And I think, I don't know how many autoimmune diseases we've actually, kind of have a name for. Was there maybe 100 or something like that? There's probably a lot more autoimmunity that's happening. And I think a lot of people with chronic pain have some local, maybe even systemic immune system dysregulation. And we can't think about systemic immune system dysregulation without thinking about the integrity of the intestinal microbiome and the integrity of the intestinal barrier. It just all goes hand in hand, because if somebody has compromised to their intestinal barrier, they're having, inflammatory substances from inside their gastrointestinal tract getting into their circulation superhighway, and it's going all over the body. And oftentimes in inflammatory areas, those inflammatory substances just kind of settle, and it can really exacerbate their issue. So if we could identify and treat their integrity of their intestinal barrier and their gut microbiome, I know that we're going to have more success with that patient. When I see improvement in a person's intestinal barrier and intestinal microbiome, then I know that they're going to feel better. We try to put as many pieces as we can into it, but if we can get just that one thing to improve, I know that there's going to be beneficial knock-on effects in the rest of their system.
You're doing intestinal permeability testing and food sensitivity testing with your
absolutely
chronic pain patients?
I do the testing. I like to see the numbers, like to show the numbers. I draw all over the
which specific labs are you doing for chronic pain for that immune diet?
Yeah, so the majority of people who come with chronic pain are following a fairly standard American diet, which is heavy in wheat and gluten, dairy, and other commonly reactive foods. So I'll use more often than not, just as part of kind of basic lab testing, I'll use Cyrex Array 2, Array 3X, and Array 4. And that gives me a whole bunch of cool clinical information. On the Array 2, I get markers associated with the integrity of the intestinal barrier, occludin, zonulin, actomyosin, and then we also get lipopolysaccharides. LPS is an endotoxin produced by gram-negative bacteria. So it's also kind of a proxy for dysbiosis. So just that one marker can let me know if they have disruption of their intestinal microbiome with that LPS marker. And then we have the Array 3X, which is the deepest dive that's available for wheat and gluten and even non-gluten wheat proteins. And then we have Array 4. I think the best thing around the Cyrex Array 4 are the dairy markers. So we have a very comprehensive evaluation of dairy and some other foods. There's other foods on the Array 4 as well, egg and corn and some other things, rice. But also, I think the dairy is the best thing about it. Then we have the wheat and gluten on Array 3, and then gut barrier and a marker for dysbiosis on Array 2. That's a whole bunch of cool clinical data to start with. And I can be very specific. I can be targeted with my therapy based on that information, as opposed to taking a shotgun approach and going, here's all the stuff that I think you need to do for your gut. Oh, actually, based on the results, you got to do this and this. And actually, we don't have to do these other things. And so it allows me to be kind of more of a sharpshooter with the way that we address it.
So Chad, we talked about with people that have chronic pain and just the dietary component. I know there's so many treatment applications that you can go into, but as far as the dietary component, balancing blood sugar levels, making sure they're not having a roller coaster ride, making sure they're not hypoglycemic, making sure they're insulin resistant, making sure that they have some ketogenic activity throughout the day, having these anti-inflammatory effects, whether it's a ketogenic diet for a period of time or just ketogenic periods with time restricted feeding. And we talked about how important essential fatty acids are into their diet and having healthy fats. Talked about how important protein is, not being protein deficient. And we talked about things like intestinal permeability and food sensitivity. Are there any other major dietary mechanisms that everyone should know about chronic pain that we're missing?
Yeah, the other thing is proper hydration. There's some, markers that you can see, or even just based on, different symptoms and kind of clinical picture, you can tell if somebody has even mild degree of dehydration. Oftentimes what's going on in a joint or a joint capsule is dehydration. They've had like chronic dehydration for probably years. And if we can just get them hydrated, it helps with so many things. I think it helps right there locally at the synovial joint level, but I think it also influences the central nervous system and the neurons in the brain. I mean, if you can correct me if I'm wrong about this, but I think the brain is probably about the same amount of water as the earth, which I think is between like 70 and 75%. So it's really, really key to hydrate, because it's our brain that's ultimately letting us know if we have pain or not. And I think it's just a little bit of mild dehydration. I think there could be significant influence in our perception of pain. So hydration always is a key component of what we talk about.
Nice. So I always end with a comment, feedback. So we have two different groups in our community, new functional medicine practitioners that are just learning, and then really advanced ones. What kind of advice would you give for new functional medicine practitioners jumping into this world? And then what kind of advice you give to people that have been doing this for a long time, advanced ones, from your perspective?
Yeah, I think the new ones, you got to stay curious. I think you got to follow your curiosity. And as you get curious about, different things, I think try to take as deep of a dive with that thing as you can, and be authentic with the way that you approach your patients. I think mimicking somebody like Datis is very smart. And at a certain point, you're going to start to make things your own, and you're going to have your own individual, authentic way of addressing. And how do you want to, this is your life, a big part of your life is helping patients. And how do you want to express yourself using that as a vehicle, and following your passion, getting curious, and taking a deeper dive with those things that you're really curious about? Because so much of this comes down to energy. Like, we only have so much energy that we could kind of have during the day. And if we're curious and we're passionate about something, it doesn't take much energy to take a deeper dive. If something is a struggle, then you're not going to stick with that for very long. So I would encourage you with, the human body and health and fitness and kind of the whole way the body works, really follow your curiosities and turn that into a passion, and, cool, awesome things will happen. That's for kind of the newbie, and maybe a little bit for somebody who's been doing it for a while also, just to kind of rekindle their excitement, could be also following curiosity. But I would say, try to learn something outside of your field. If you've been doing this for a while, start to read books outside of your field. And what you'll find is you'll make some creative connections between other fairly disparate topics, and you'll connect that and go, oh, they're doing that in engineering. I wonder how I could weave that concept into working with my patients. So I think learning things outside the profession, but still, and you have no choice of doing this, you're going to read that through the lens of what you understand about human health, and you might make some cool kind of creative connections in that way.
Awesome. Thank you, Chad, Dr. Larson. Good to see you again, and we'll connect soon, and thanks again.
It's a real honor to see us. I hope we can hang out soon. We'll talk to you later.